Kalispera. I think this is the moment we switch in English now for this panel, if I'm not mistaken. Hello, everyone. So my name is Danai Spentzou. I'm here together with Zisis Kozlakidis. It's a very good and honest moment to talk about healthcare innovation and clinical trials. I think it's the heart of the discussion happening in the last few months. I am a lawyer by background. I have been working, though, in the last 4 years in the European Parliament as a scientific advisor for the Committees of Environment and Public Health. I'm doing my research on bioengineering and gene editing, and I'm also the coordinator of 2 initiatives that they're trying to bring together experts on health policy, and Young Voices in Health Policy and the Greek Voices in Health Policy, trying also to connect what is happening in the EU level and the national level. And I have the honor to have next to me Zisis Kozlakidis, the head of laboratory services and biobanking at IARC, the International Agency for Research for Cancer of World Health Organization, based in Lyon, France, where we had also the pleasure to be hosted last May and to have a tour of the largest facilities in biobanking in Europe and worldwide. Zisis has several years of experience on the healthcare sector as a consultant, expert, biobanking, virology. I think it would be hard to go through everything considering the time we have, because you also worked in many different countries and sites in the EU, US, Asia, Africa. And you have also, you're a visiting professor in many universities. You have awards on virology and biobanking. But what is most important, I would like to really focus on, is that I've met you personally, and I know how much you care about your work and how much impactful changes you want to make, which is very wonderful to see that when someone's so dedicated to their field. So let's try to start the discussion now. Briefly, when we discussed before, we said that there are so many things and innovation happening in that field and clinical trials, and we have a lot of clinical data now, biobanking, data sharing. But in practice, we have all these initiatives and good intentions, but in practice, when we try to implement them, we see that we face a lot of barriers, whether it is regulatory, whether it is financing, many other reasons also. Do you want to give us some examples and go through the landscape for now, and then we will discuss separately the barriers?
Yeah, absolutely. I would want to say also thank you all for coming. And I really like how you put from diplomacy to health diplomacy. I think it makes a lot of sense. So when it comes to clinical trials, we see a very pronounced shift when it comes to Europe. So the absolute number of clinical trials in the last 10 years, let's say, has risen by about 40%, and the pandemic was a massive catalyst for this. However, the market share of the European Union has decreased at the same time. So whereas the European Union held about 22-25% of the market share in clinical trials, now we're looking at about 12%. So something is not really promoting, something is de-incentivizing the companies and startups to start clinical trials within the European Union. When we look at that, of course, if you ask people what's your problem, they'll give you a very, very long list of problems. But mainly it's the regulatory burden that's gone up. And from a WHO point of view, this is quite significant. Why? Because you can have an important, well, there are 2 reasons. First of all, we've reduced the number of clinical trials, which means in 10 years, over 500,000 of patients are not receiving new treatments in Europe, which is an ethical problem and a practical problem. The second reason is that by doing so, we've increased the burden to such an extent. Before you start doing anything, administering a treatment, for example, you have to spend at least 18 months to 2 years in satisfying regulatory provisions. So that is a huge cost that, for example, an SME cannot take care of. It's already a cycle for an SME, 2 years.
Absolutely. I think even for medical devices, for example, we can see differences between the EU and the US of even 5 years for a very simple device. So in clinical trials, that it's an even more complicated procedure, this makes a greater impact. Can you give maybe more, if you were to change something, if you were to advise the policymakers to change something?
I do advise them.
It's difficult, but because it's important to have the input from someone that is on the field. And there is a simplification effort happening now in the European Union. But unfortunately, it's focusing more maybe on other fields, not so much on the health field. And at the same time, we have very big initiatives taking place, like the revision of the European pharma legislation and the upcoming Biotech Act. So if you wanted to give a message to the policymakers, how they can change that and bring more incentives back to Europe, would it be cutting down procedure and red tape or more funding?
Yes, so thank you for this. Our advice has been fairly constant in the last few years. The first one is to defragment the legal landscape. The way that the European legislation has been implemented as a national, with all kinds of different national flavors, let's say, it's really prohibitive for large clinical trials to initiate. So the one is the defragmentation. The second is to provide real incentives. So yes, simplification is good, but it doesn't incentivize the creation, the innovation to come into Europe or from Europe or to stay within Europe. So there are these translational steps that further attention needs to be taken.
Absolutely, this makes sense. And if we talk about it now in the current geopolitical scenario, maybe, do we see some more drivers for companies or research centers to come back in Europe, or still they would rather stay in the US? Like, because there is a lot of uncertainty now with the political situation and the governments of Trump, so maybe we see an advantage situation for Europe, or still we don't see this window?
I would refrain from putting a position of something versus something else. We're just moving into a multipolar world, and that's absolutely fine. We've been there before. We've had experience of what works and what doesn't in this situation. So it's a case of adapting what we already have to fit the new landscape that emerges. What it's important to understand is that we're not alone. So whatever is initiated in Europe at some point has to go to bigger markets. And these bigger markets would be the US, Sub-Saharan Africa, if it's for low-cost devices, for example, or Southeast Asia. So whatever we do, we need to create these bridges. So it's important that Europe already has preparation sufficient enough to have these bridges to allow these companies to develop.
Yes, of course. And maybe if we can touch another topic that also has not been in the center of the discussions or researches for many, many years and decades. So there is more and more discussion about diversity in clinical trials and inclusivity. What if we can have more information and data on women and children? And of course ethnicity, but with a specific focus on the two first, because we are lacking a lot of data so far. Do you think there is, why historically there has been such a scenario, and if there is a shift now to include more data?
Thank you for the question. This is something that goes to the heart of what the World Health Organization is trying to do, which is to increase the capacity, especially in low middle income countries, to reduce disparities and increase the equity. Traditionally, the data that we have comes from North America and North Europe. This is understandable because that's where the technology developed, where the money was. But if you look at, for example, the genomic databases, human genomic databases, and you question what's the number of Black African individuals from Sub-Saharan Africa represented there, the number is less than 4 or 3%. And it's the same for Hispanic individuals from Central South America. It's a very low number. Even if you divide by country, it becomes so small that's meaningless. So what we need to do is we need to develop and open our horizons. From the World Health Organization perspective, we support several genomic projects, national genomic projects. So, for example, at the moment, we are working very closely with the governments of Egypt, Qatar, Indonesia, Thailand, Malaysia, to develop the National Genomic Project to redress this balance. Now, this is going to happen, but it's going to happen in a horizon of about 5-10 years from now. So what we do in between is we try to include those groups that have not been represented, such as women and children. So in the short, medium term, and that's why you have, for example, the Childhood Initiative on Cancer by the WHO, because we need to redress that problem. It's a significant problem because we have several clinical trials where the treatment has been very promising. When it's been implemented in practice, the impact has been less than satisfactory, let's say incremental. And for the amount of funding, effort, time that's been spent, it's actually not well spent for the health of the individuals involved.
And I guess when it comes to specifically rare diseases and cancer, rare diseases for oncology for children also, then it's even harder to have clinical trials. Do you think there could be something that we could do there?
Yes, I mean, our view is that eventually most cancers will become rare diseases because we'll start stratifying and classifying by the genomic information, the physiology that you see. So the treatment would need to be absolutely personalized to be effective. The issue with the children is slightly different. So in the case of children, we had the situation of adult protocols, adult processes, let's say, that we retrospectively fit for children because we treat them as adults of younger age. And this is not appropriate. It's a different physiology that you're dealing with, so you need to adapt from the beginning for the children. So this is in progress, but not there yet.
It's interesting to see that the more personalized we make treatments and research, the more difficulties then we might cause and then exclude a certain category of patients when we try to find the best treatment for them. So it's interesting to see that. Do you think in the context of artificial intelligence, will it be easier, or how can artificial intelligence in general redefine how we conduct clinical trials?
Yeah, this is a very long answer. But the artificial intelligence is a question that is front and back of our mind. Last year we published guidelines on how artificial intelligence should be incorporated into healthcare. But these guidelines are very high level. So if you read them, it's a lot of, it would be good to do something like this, or you should strive to do something. It doesn't actually tell you how. And there is one of the reasons is because we don't have enough case studies from across the world. Most of our case studies come from very specific geographies. So what we have addressed is the development of regional collaborations for the development of artificial intelligence. So when we're working with partners in Southeast Asia, we promote regional collaboration for artificial intelligence, for data sharing, for healthcare specifically. For example, last year in May, in 2024, the ASEAN, so this is the group of 11 countries in Southeast Asia, like EU Light, if you like, they signed a declaration for AI in healthcare, and they agreed to work together, ignoring the rest of the world, but working together because their problems are quite specific, and see how artificial intelligence will address those problems. Now, this is what we see. We see regional differences, and I think the regional differences will become even more pronounced when we move ahead. The other question is, what do we do right here, right now? Well, right here, right now, we are using it. So if you go to radiology, most of the radiology devices have some sort of artificial intelligence incorporated into them. The question that we have is, do we have sufficient number of well-trained staff to actually use the artificial intelligence? The technology is moving far quicker than we can train the clinicians and the physicians to use them in a reasonable and effective way. And this is going to become even a bigger need as we move forward, because the more personalized the medicine becomes, the more transdisciplinary it becomes. So the person that needs to administer the treatment needs to be aware of a lot of other fields. Now, do we have sufficient number of people to train them? No. So we have to develop the support system to allow for this to happen.
Indeed, there are many factors to take into account, and also we are talking about shortages of healthcare professionals in principle, and then more so when it comes to more specialized areas. So it's finding one solution and then keep on having something else to look forward to solve again. But when we talk also about biobanking and data sharing, can artificial intelligence also elaborate and enhance most these capacities we have now in facilities for data sharing and digital health?
What we have is, at least in Europe, there is the realization, better late than never, that the data that we have in healthcare is actually useful for clinical trials. So what we need to do is we need to have the clinical trials and then allow for some flexibility to embed real-world data that comes from biobanks, from university healthcare systems, into the clinical trial. So what we have as a perfectly selected group of patients that we want to test a treatment is complemented by patients that are necessarily not that perfect, but more realistic. And that allows the system to be more effective in predicting whether this treatment would be effective or not. The European health data space that is under preparation at the moment is promising, but there is a big elephant in the room. Once we have all the data, which is going to be only a couple of years from now, how are we going to share this data with, say, for example, US partners or China or Singapore, which are other very mature infrastructures that would hold equivalent numbers of data, but we need to work together to find the answers.
I think here it's very important to see where we can have interdisciplinary opportunities and collaborations among countries, but also public-private initiatives. For example, so far the H2O observatories has been very successful in collecting data on health data, and then how this will be also enhanced now in the landscape of the European health data space, or other initiatives like the one we are also working together, like the digital hub innovation or similar things that are very important, will have a crucial role into this.
Yes, absolutely. We really need to increase the digital health literacy of the population. If you compare the digital health literacy of Southeast Asia versus Europe, they're way ahead of us. So we need to be competitive. We need to increase our digital health literacy. Absolutely, initiatives such as the digital hub, they're crucial to engage individuals. It may be that you don't really want to be the expert in everything, but you need to be aware. At the moment, what is happening, and it's one of the reasons why several innovations fail, is that the innovation is fantastic. We have many, many examples of very good innovations, but they're discovered, they're thrown over the fence for the clinicians to operate them, and these individuals have never been trained. They don't really know how to get the best out of this innovation, and then it just dissipates and fails. And it doesn't have to be Greece. This is universal across many locations. I can name, at least in the UK, 2 very high-level innovations that were very successful in the impact, but the implementation by the clinician was so misaligned that at the end the whole system collapsed.
In literacy and education on that field in general can be more helpful also to how then implement the initiatives that are taking place and the information someone is receiving to have the better outcome. Maybe one last point we can discuss when we are talking about best practices and innovations and now changing the ways we're conducting clinical trials with more digital health and artificial intelligence. do you see also an opportunity to make the healthcare system, to redefine it in a way that is more patient-oriented, as we said, from one hand, but also good for the environment and sustainability under the concept of One Health to connect maybe these two aspects together?
Yeah, this is very interesting. So digital health and green policies, they don't really go together. The one is absolutely energy sapping, and we try to preserve. I think there will be a common point where the two meet.
I think it's so far from the experience we have also in the discussions in the institutions is that this is the mistake, that the one is really connected with the other if we want to really redefine the healthcare system, to have it more energy sufficient, less polluting, with less waste, and then also running clinical trials and using less medicine, having again less weight, more dedicated sources, because first you might run it with digitally with in vitro diagnostics or with clinical trials, and then taste it to the patient. So also then
absolutely. So I will answer in two ways. The short one is we don't actually have enough data to answer to this question. The long answer is that we know that we need the AI. We need AI in many forms, especially in clinical trials. There are ways to implement it in such a way that it becomes useful as a predictive tool, but there are many problems that we also face. The one is liability. So if the AI hallucinates, predicts something that's not true, where does the liability lie? We don't know. We really don't know. And there have been some cases, legal cases, in a few countries, but the outcome is very disparate. You cannot say this is a consensus. We're far from a consensus, I think. The second is, when it comes to the clinical trials, there is still a lack of understanding from the patient perspective as to what AI will do for them. So I think we need to manage the expectations as to what the AI may predict. In some cases, you can crack it and you don't need a laser beam. The outcome is still the same. And the expectation of the patient is for complete cure, and that's not always the same. The AI may very well predict that what we're doing so far is sufficient.
It's a very vicious circle. We are lacking data on something and we cannot address it, but at the same time, this is the way to move forward. So maybe we can also open the floor for questions, and if you have one last positive message, do you see that we are shifting in a way that we will have more clinical trials conducted in EU, or to speed up the process, better outcome, just as a vision, as a
So as a vision,
ambition.
let me say, I think we need to consider that where we are going is a completely different world. So the children that are born today will never be as clever as the AI that is developed today, but will have 18 years to mature. So this is a different world that we'll move in, and we need to prepare for that. For the AI, we need to make sure that we define the boundaries. There are several boundaries that are very unclear at the moment. Beyond the liability, the hallucination thing. We will have several different models of AI. How do we compare? How do we, from a clinical perspective, how do we validate what the AI model is predicting so that we make sure that we move towards a guideline? So there are many questions, but that's the direction of travel, and we need to be bold. We need to go with it, and actually a few of the panel said that before, and just do the best we can.
I really like this message. So does anyone have any question? Yes.
Good morning. Thank you very much for the insights. Συγγνώμη. Λόγω της συζήτησης περισσότερο. Καλημέρα σας. Σας ευχαριστούμε πάρα πολύ για το πολύ ενδιαφέρον insight που μας προσφέρατε. Θα ήθελα να σας ρωτήσω από το regulatory perspective, Θα μπορούσατε ίσως να μας δώσετε κάποια παραδείγματα κάποιων εμποδίων που συμβάλλουν σε αυτό το χαμηλό ποσοστό κλινικών μελετών που αναφέρονται πως διεξάγονται στην Ευρωπαϊκή Ένωση. Και επιπλέον, θα ήθελα να μου απαντήσετε αν θα αποδίδατε αυτό το lack of incentive σε ένα overcomplicated regulatory framework.
Μπορείτε να επαναλάβετε το κομμάτι.
Ναι, βεβαίως. Θα ήθελα να μου απαντήσετε άμα θα αποδίδατε αυτό το lack of incentive που συζητήσατε σε ένα overcomplicated regulatory framework. Άμα όλη η διαδικασία είναι πάρα πολύ...
κατάλαβα. Okay. So the question of the incentives, it's what we would call a hyper-complex problem. So you cannot do one thing and will become a solution. The two main elements are the fragmentation that we have in the European Union. The lack of stability is the second one, because, okay, the EU as a central organization wants to defragment, that's absolutely clear, and we see actually several initiatives that are taking place. But still, it has to be implemented locally. And that local implementation comes with all the different colors of the rainbow, let's say. And this is not a way that you can predict, say, from the pharma perspective when you start a clinical trial. So we need to have this long-term stability and predictability. The second is that we've just introduced in the EU the AI Act, which will have another round of implementation and will create yet another colorful landscape. So this is going to work as a negative incentive for investment. Again, it's not because we don't know. We want to go that way. It's just the process of working through the system and allowing the system to find the place to stabilize is a bit too long.
If I may add to that, I'm sorry for that, it's also harmonization among different simplification efforts and coordination, because we might see an initiative now simplifying one law that will allow for clinical trials to take place faster, cutting down on process from EMA or from authorization. And then you might need the tool for the clinical trial to be reviewed every 5 years. And it can be a very simple tool, like a Caesar. And then when you are postponed, you might even end up postponing the whole trial because the tool that you need, which is regulated by different legislation, has to be reviewed again. So it's also better coordination on that part.
But for a lot of this legal, I can see AI being implemented to fill in the forms. So AI will become a solution to that problem and will speed up.
Thank you very much.
Thank you then very much.
Yeah, I'll be here all day. Happy to take any questions. Let's discuss. And Greek and English doesn't matter. We can do French as well.
Thank you, Zisis.